Hello and welcome. Today, we're diving deep into an area of clinical practice that is, let's be honest, incredibly complex: managing infections in patients with significant renal or hepatic impairment. This is where the standard playbook just doesn't cut it, and where true clinical acumen really shines. So here's our roadmap. We're going to start by building a foundation, really understanding the risks these patients face. Then, we'll put that knowledge to work with a case study on peritonitis. After that, we'll walk the pharmacokinetic tightrope of drug dosing, tackle the crisis of acute liver failure, and wrap up by shifting our focus to prevention. This right here, this is the heart of the matter. It perfectly captures the essence of what we're talking about today. For these vulnerable patients, every decision, especially around dosing, is balanced on a knife's edge. It's not just about what you know. It's about being constantly, relentlessly vigilant. All right, let's get into our first section. We have to start by understanding why these patients are considered compromised hosts. It's more than just a label. Organ dysfunction fundamentally rewires their susceptibility to infection and changes how a disease will play out. And you can see just how wide-ranging this vulnerability is. It's not siloed to one type of infection. For viral illnesses like COVID-19 or the flu, renal failure is a clear signal for a rougher course. It even extends to parasitic infections, like scabies, which can become much more severe. And when we look at bacteria, the risks are profound. Hemodialysis patients are far more likely to see a localized SRES infection spread throughout the body. Even a common skin infection like cellulitis can become a major threat in someone with cirrhosis. So, let's take these principles and apply them to a real-world scenario. We're going to dissect peritonitis in the context of peritoneal dialysis, or PD. This is, without a doubt, the most common and serious complication these patients face. Diagnosing PD-associated peritonitis isn't about one single finding. It's about connecting the dots. It almost always starts with the patient's subjective complaint, new abdominal pain. Then comes the objective visual cue that every PD patient and nurse knows to look for: cloudy or turbid, effluent fluid. The lab then needs to back this up, showing a leukocyte count over the threshold with a neutrophil predominance. And of course, the definitive confirmation comes from growing the bug in culture. Now, what's fascinating are the risk factors. It's easy to just blame extrinsic factors, like a contamination event, but we have to think deeper. There are intrinsic patient factors. Something as seemingly simple as hypokalemia can increase risk. And there are iatrogenic factors, things we do, like prescribing gastric acid suppressants, which can increase the risk of peritonitis from gut bacteria. This is why getting that diagnosis right, starting with a perfect specimen collection at the bedside, is absolutely critical. Okay, time for a clinical challenge. You've got a classic presentation of PD peritonitis. The gram stain is already pointing you toward a gram-positive culprit. You know that catheter biofilm is a huge concern here. So, looking at these options, what is your single most appropriate initial move?
The correct answer here is C, and it's a beautifully aggressive strategy designed to save that catheter. You're not just treating the bug, you're attacking its fortress, the biofilm. The intraperitoneal vancomycin handles the gram-positive cocci, but the real key is adding rifamycin, which is a master at penetrating biofilms. Then, you bring in the urokinase lock. Think of it as a demolition agent. It breaks up the fibrin scaffolding that protects the bacteria, allowing the antibiotics to get in and do their job. It's a sophisticated play to avoid the drastic step of catheter removal.
This case leads us perfectly into our next section, which is the daily tightrope walk of pharmacology in these patients. This isn't just about reducing a dose by 25%. It's about fundamentally rethinking a drug's entire journey through a body whose clearance systems are compromised. And just look at this table. It screams one thing: there is no universal rule. For drugs like gentamicin and vancomycin, you are flying blind without therapeutic drug monitoring. For others, like nitrofurantoin or foscarnet, there are hard stops, absolute contraindications below a certain level of kidney function. And then you have a drug like metronidazole, which is largely renal independent but requires a massive dose cut in the face of severe liver disease. You have to know each drug's specific profile. Looking specifically at the liver, the adjustments fall on a spectrum. On one hand, you have a drug like metronidazole. In severe liver disease, its metabolism tanks, so you have to slash the dose by 2/3 to avoid toxicity. But on the other hand, you have drugs like rifampicin and pyrazinamide. Here, the risk of causing further liver injury is so high that they become completely off limits in patients with pre-existing liver disease.
So let's do a quick knowledge check on that point. We just mentioned nitrofurantoin. It's a workhorse for UTIs, but it has a very strict rule when it comes to renal impairment. At which one of these levels of renal function does it become absolutely contraindicated?
The answer is C, a creatinine clearance of 45 milliliters per minute, because the hard cutoff is 50. And this isn't arbitrary. It's based on a crucial dual mechanism of failure. First, efficacy. Below this threshold, the kidneys simply can't push enough of the drug into the urine to kill the bacteria. It won't work. Second, toxicity. Because the drug isn't being cleared, it accumulates in the bloodstream, raising the risk for serious systemic side effects. So it becomes both ineffective and more dangerous at the same time.
Okay, let's pivot now from the complexities of chronic management to an all-out 5-alarm fire, acute liver failure. This is a true medical emergency that demands a rapid, coordinated, and multidisciplinary response from the moment the patient hits the door. The definition itself tells you how serious this is. It's not just one thing. It's a triad. You need evidence of rapid and severe liver injury. You need proof of impaired synthetic function, that's the coagulopathy, the INR greater than 1.5, and you need the devastating neurological consequence of hepatic encephalopathy. And critically, this all happens in someone who did not have chronic liver disease before. So, here is our final case, and it's as critical as they come. Your patient with ALF is now in grade 3 encephalopathy. They are profoundly confused, barely rousable, and cannot protect their own airway. In this exact moment, what is the single most important life-saving thing you must do?
The answer is C. Without a moment's hesitation, you intubate. This is airway, breathing, circulation 101. Once a patient hits grade 3 or 4 encephalopathy, their protective reflexes, their gag, their cough are gone. The risk of aspirating and developing a fatal pneumonia is sky high. Securing that airway with an endotracheal tube is the absolute top priority. Everything else, antibiotics, diagnostics, everything comes after. Okay, after all that intensity, let's just take a breath for 1 second before we get into our final topic. All right, for our last section, we're going to shift our mindset. We've talked a lot about reacting to infections. Now let's talk about getting ahead of them. How do we use our understanding of organ impairment to proactively and safely protect these vulnerable patients? HIV pre-exposure prophylaxis, or PrEP, is a fantastic case study for this. For a patient with kidney issues, the rules are strict and clear. PrEP is a no-go if the eGFR is below 50. You need regular monitoring of kidney function, and you have to be vigilant about avoiding other kidney toxic drugs like NSAIDs. Now switch to a patient with liver impairment. The considerations are completely different. PrEP can actually be used in someone with chronic hepatitis B, but it takes specialist oversight and strict daily adherence. It's a perfect illustration of a tailored, organ-specific approach to prevention.
And that leaves us with a final thought to consider. As our patient population gets older and taking multiple medications becomes the rule rather than the exception, is this kind of highly specific, organ function-based dosing really just a niche specialty? Or is it, in fact, the next great frontier of truly personalized medicine?